Uh, Now I'm talking about revision rotator cuff repair, except the SCL. SCL already Terry told about that. So how to handle failed rotator cuff repair? Important thing is don't make failed rotator cuff repair. How? Appropriate procedures from pre-op to post-op. Pre-operatively, we need to know our own repairability. So that's why we need to choose appropriate treatment option. Intraoperatively, we need to choose appropriate technique between repair or augmentation. Postoperatively, definitely appropriate rehabilitation is very important. If repair is inevitable, make an asymptomatic rotator cuff failure. For assessment of tear repairability preoperatively, we need to use clinical findings, plain radiographs, and MRI. It will be very helpful if everybody has their own repairability index. So I analyzed my patient who had a rotator cuff tear more than 2 cm. So I analyzed this kind of imaging factors and functions and then run statistics. I obtained the cutoff values and odds ratio. My repairability index is that highest odds ratio is muscle atrophy of supraspinatus. Then next is the fatty infiltration of infraspinatus, grade more than 2, and then tear length, ML size more than 26 millimeters, remnant tendon less than 50 millimeters. Using that score, I analyze and then I assess my repairability preoperatively. Intraoperatively, I need to do some augmentation. For ortho tendon, I use biceps augmentation, usually in anterior L-shaped rotator cuff tear. You see, there are three ways to use biceps as augmentation materials. I like to use the anterior cable reconstruction after cutting the distal part of biceps tendon. So the principle is I put biceps using two tenodesis point. So medial tenodesis, I put anchors where the infraspinatus can come anteriorly as possible. After tenodesis, and I put my biceps beside the infra. Using those sutures, I tied it together, supra and then infra on the biceps. And then lateral tenodesis, also I put anchors where the infraspinatus can come anteriorly. So I can repair the infra and the supra without undue tension, and that biceps tendon as an autograft and then roll as a anterior cables. So my repair rate is about 18%. Once supraspinatus can come to the medial part of footprint after medialization without less tension, I do patch augmentation like this. So preoperatively, that much tear, and I put patch augmentation. The post-op 6 months MRI shows that patch is intact, and then below that, there is a tendon-like soft tissue is regenerate. We can see. Definitely SCL I do to reduce the retear. Not like Tero, I use acellular dermal matrix. The thickness is more than 4 to 5 millimeters. And then I made extra 15 millimeters medial side of ADM. So I can those part push below the remnant supraspinous tendon. And then I use the customized lateral portal divider not to tangle the sutures, and then to reduce the number of sutures to the subaqueous space, I use dual pulley technique on medial side. And I suture with remnant rotator cuff tendon. That's my tip to reduce the retear rate after SCL. That's my technique. And then briefly, that's my lateral portal divider, and then preparation outside the shoulder, and then pre-back, lateral suture bridge technique, and then medial, I sutured my graft with a remnant supraspinous tendon, and then post side-to-side repair 6 months after operation. Anyway, all this effort preoperatively, intraoperatively, still repair rates so high from ranges from 10% to 57%. But patients repair. Sometimes they don't have symptoms and sometimes they have. There are a lot of factors was introduced related with repairs. So age, preoperative size, fatty infiltration. And also I want to know my repair factors, which causes repair. So my analysis is that initial tear size and then fatty degeneration more than grade 3 is closely related with my repair factors. But everybody knows that repair doesn't mean poor functional prognosis. Pain relief and function improves despite of repair. So repair alone did not affect patient satisfaction. But sometimes we meet the repair patient with highly symptomatic patients. So that was my question. I was curious about what causes symptomatic failed rotator cuff repair. So in my repair patients, I analyzed and then I divided into two groups. Symptomatic failed rotator cuff repair who needs revision surgeries compared to the failed rotator cuff repair with or without symptoms. So most powerful predictor of symptomatic failed rotator cuff repair is the relative tear size change of AP diameters. Second is the ML diameters. So see this. So preoperative tear size like that. After repair it, I got repair. But if you compare the AP size, pre-op and post-op MRI, the post-op MRI is larger than preoperative AP tear size. This patient has a high chance to have symptoms. But if you compare this one, the large tear, when I repair it, although I have a repair, but when I compare the post-op AP tear size to the pre-op AP tear size, repair size was smaller. So this patient has a less chance to have symptoms. So independent predictor of symptomatic failed rotator cuff repair is relative change in AP tear size. So other thing is the serum cholesterol and then fatty degeneration infraspinatus was closely related with symptomatic repair. So every time I do repair, I always think about if repair occurs, how can I avoid the symptoms? So try to reduce AP direction tear size. So in this kind of large tear, using one pair of sutures like that, you see that I sutured in horizontal matrix pattern, then that sutures independently blocks its way to progression. So other sutures, I use those sutures for suture bridge technique, but this, I call it stopping sutures. Whenever the retear occurs from anterior, that horizontal matrix will block its progress to the posterior side to try to reduce the APTL size. So improved clinical outcomes after repair, we know why. So I think the subaqueous decompression and debridement will definitely have a role to reduce the symptoms. Definitely repair is smaller than original tear size. That causes restore the false couple that leads to less symptom after repair. And then another paper said that active patient has more poor function and structural failure with the repair after repair. And then another question is when do we do revision surgeries? So I found that revision surgeries, who needs revision surgery within 1 year after primary repair has a significantly worse clinical outcomes after primary surgery. And then tendon to bone area healing failure, and then full thickness tear of subscapularis. This patient has a chance to have early revision surgeries, but muscle weakness is main cause of late revision surgeries. Still, revision surgery is challenging. The challenging because we concomitant lesions that which is not found detected on MRI, and then adhesion of cuff tissues with acromion or deltoid, and then consider previous anchor fixation site that just where we need to put. So these kind of technical problems we can meet in the revision surgeries. So unpredictable tendon quality. If you see this one before debridement, it looks so small retail size, but after debridement, that small retail size becomes a large, and we need some kind of augmentation for that. Anyway, still, once you decide the revision surgery, you need to set your revision timing based on patient symptom, and then revision technique, patient age, and then retail size. Definitely, we can use these 6 techniques. You can repair completely again, and then partial repair and autograft, partial repair or allograft, tendon transfer, and then SCL, and then finally reverse shoulder arthroplasty. So this kind of revision repair, the post-op AP size is not that big, so we can repair directly using other suture techniques, suture repair techniques. Once I debride this retone tendon, it looks like U-shaped. So I use modified double row fixation technique using 2 suture anchors. I gather that tendons together side by side. That's kind of side to side repair using suture as uh, suture anchors. So in that case, we can obtain the good result and then good tendon continuity with a higher satisfaction from the patient. So clinical outcomes, definitely after rotator cuff re-repair, the significant improvement we can obtain, but not as good as primary repair. So comparable short-term outcomes, but still higher repair rate. So factors related to repair after revision surgery is preoperative, supraspinal atrophy, and fatty infiltration are the most contributing factors re-repair after uh, primary rotator cuff repair. So we can revision using SCL, but it will be the same technique that Tara showed, and I will skip that. So we can use patch augmentation as a revision technique. So there's a remnant suture anchors. I cut the biceps. After debridement, I assess the tendon of the retracted supraspinatus tendon. I removed all sutures. Once retracted supraspinatus can come to the medialized footprint, I decide to use patch augmentation. So after put suture anchors in the medial part, and then I pass the sutures to use a suture bridge technique. So after touch down those tendons to the medial side of footprint, using those sutures, I passed the patch augmentation. I use the dimension is 2.3 millimeters, 3 centimeters, and then thickness is 2 to 3 millimeters ADM I use. So I can get that patch augmentation for repair revision technique. So repair doesn't occur, and then post-op MRI shows a good collaboration with patch and then repaired tendons. So, but still revision with patch augmentation has a higher failure rate, 30 to 34% has been reported. So revision using autograft. So as I mentioned earlier, I use biceps tendon as the autograft. In that kind of revision surgeries, it's kind of L shape. I can use it biceps tendon after cut the distal part. But in that case, the return tendon is always weaker than the primary tendons. So I try to put biceps or patch as augmentation material. So medial tenodesis, and then using those sutures, I passed supra and then infra. Try to put the supra and infra together on the biceps to reduce the tension. And then I try to put my biceps just beside the infraspinatus. And then I try to take my infra to the anterior as possible. Once that technique has failed, but still my retail patients still have a smaller AP diameter compared to the preoperative tail size, then I can have a higher chance to have a asymptomatic retear. So always try to reduce AP tail size. This is post-op MRI. And then revision using RSA, definitely elderly patient with massive tear. I don't have any hesitation to have a arthroplasty as a revision technique. So clinical outcomes reverse, it's a comparable, but the shoulder arthroscopy performed within 2 years before shoulder arthroplasty is associated with a higher infection rate. You need to remember this. So take-home message. So choose appropriate treatment method after assessment of preoperative repairability, and then try to reduce AP dimension to avoid symptomatic rotator cuff failure. Revision timing is determined based on patient symptom. Applied various revision surgical methods based on patient age and then rotator cuff retail size. Thank you for your attention.